professor in the Department of Health Policy and Management. She received her PhD in public policy from the University of Chicago, an MPH in health metrics and evaluation from the University of Washington, and had bachelor's in psychology from Harvard University. Dr. Myerson studies how public policies influence health systems, health insurance coverage, access to care, and health outcomes. Her work combines econometric with a strong commitment to informing policy decisions that improve equity as well as access in the healthcare system. Dr. Myerson's work has been published in very outstanding journals such as JAMA, Health Affairs, Social Science and Medicine, and has been featured in major news outlets, including the Washington Post, CNN, and Bloomberg News. Her ongoing projects address pressing questions around Medicaid renewal, outreach strategies, and equitable access to essential medications. It's a great honor to introduce Dr. Rebecca Myerson, and please join me in welcoming Dr. Rebecca Myerson, who will share insights about her work, ongoing research. Over to you, Rebecca. Thank you so much.
Thank you so much for the kind introduction, and it's great to be here. I'm really looking forward to your feedback. So I'm presenting this project that is our own grant. It's funded by NIDDK. We're just wrapping up the first year or so of the grant. So a lot of data, preparation, just starting to get some results and write up our first paper. So it's a great point to get feedback on this work in progress. I'll just give I'll give a quick overview here. There'll be two parts to the talk. So first, I'll just give you an overview of the agenda of the full grant, even though we won't be able to show all the results for everything today. That gives you a little bit of a sense of where we're going with this. And then I'll show you the results that we have so far. That'll be the first paper. And please feel free to ask any questions throughout. I'm happy to discuss at any point. And you can put it either in the chat or just unmute and speak. Okay. So title of the project, Insulin, the Access and Health Outcomes After the Inflation Reduction Act's Out-of-Pocket Spending Caps. And here's our project team. Okay, so the high cost of insulin leads too many, I would say, individuals in the United States to skip insulin doses to save money. And no need to tell this group that can put people who should be using insulin at risk of a range of avoidable diabetes related complications, which could become quite severe. This particular paper focuses on a policy that targets Medicare enrollees. So in the United States, that is generally the over 65 population, although there are a couple other paths to Medicare, but that'll give you a sense of, in general, who our population of interest is. And even though all these individuals did have health insurance, Medicare being a form of health insurance, they spent quite a bit out of pocket on insulin. So one figure from 2020 is $1 billion out of pocket. So in the Medicare population, as in other populations, there is a hope that reducing the out-of-pocket costs that people have to pay for their insulin would help, reduce this phenomenon of skipping doses and improve health outcomes. This actually was done earlier in Medicare Part D. The same group we'll be studying today, but it was an opt-in model where some enhanced plans, these tended to be the more expensive plans serving kind of more advantaged individuals. They could opt into capping the out-of-pocket costs of insulin, their covered insulins at $35 per 30-day supply. So this was sort of piloted in this population, and there was some evidence that this did reduce costs and increase use in this population. However, the policy that we're studying, which came into effect in 2023, made this more equitable by basically enforcing it for all plans, all beneficiaries, basically all insulin covered by Medicare. And we can get into the weeds more of the policy and how it was implemented later, but that's the big picture. So this fits into the long-term goal of how to identify policy solutions to ensure insulin is affordable and thereby improve health. So we will be looking here at the impact of this cap that applied to all Medicare beneficiaries to reduce the out-of-pocket cost, limit the out-of-pocket cost of their insulin. on insulin access and health outcomes. And we'll also be looking at disparities across groups. Okay, so the specific aims of the grant, to get into the weeds of it a little bit more, I put in red what we will be focusing on today. Aim one, a little bit of aim two actually as well, but we're interested in evaluating the impact of the policy on out-of-pocket costs for insulin, insulin use. We have started to prepare the data on glycemic control, so I'm happy to chat with all of you about that. As you heard from my introduction, I'm not clinical myself. I have clinical collaborators, but I know there are folks with more wisdom on that than me in this room, and I would love to kind of take the discussion there as well. Okay, so why do we think this policy would affect it may be straightforward. Insulin becomes more affordable if your patients ration their insulin and health outcomes improve. But why would this vary across groups? So first, we think variation by income is likely because there were some beneficiaries who are already protected from cost sharing. So Medicare has the low income subsidy program that reduces the premiums people would pay for their Part D insurance and can also reduce their cost sharing. So we'll actually use that group as a comparison group for our study because they were really not affected by the policy. They would not have paid $35 ever. Incidentally, there's also a group of very advantaged individuals, probably higher income, who've got great, Part D insurance through their work, or can afford a really generous Part D plan, and also would have never paid $35 even without the cap. So, for whom does a $35 cap matter? Could be that lower to middle income Medicare beneficiaries. And of course, there could also be some cap people who, kind of fall through the cracks in the sense that they're not low income enough to have the full, or major cost sharing waiver. But for them, $35 might still be really expensive. So something to consider. We also wanted to test for variation by race, ethnicity, and neighborhood level segregation because one of my collaborators on the project has found that pharmacy closures have disproportionately affected neighborhoods with a larger Black and Latinx population in the United States. And there's a concern that even if insulin is affordable, if you don't have a pharmacy where you can easily fill it, then that may not be enough to guarantee access. And then finally, in our third aim, we'll be thinking about what insurance plans might do in response to this policy. So the Inflation Reduction Act policy asks them to limit the amount of out-of-pocket costs they could collect from beneficiaries. And one of our collaborators had documented that was a source of income, of course, a source of profit for them. They didn't seem to pass that all along to those profits all along to other intermediaries in full. So we might worry that perhaps they might respond to this loss of income by reducing perhaps moving around insulins on the formulary, or increasing premiums to try to pass along some of that cost to the consumer, which would of course affect access not only for insulin users but also for non-insulin users. So that's the overall scope of the project. How will we be actually doing this? We will use two main data sources, the first being the Medicare data that will capture all the fills using Medicare Part D insurance. That's the main source of drug coverage for Medicare beneficiaries nationwide. That'll capture the out-of-pocket cost. We can look, because it's individual level data, at the patterns in insulin use to see if people do have a medication gap or if they're adherent to their basal insulin. We can also look for a subset of those beneficiaries at some of their downstream healthcare use, so emergency department, inpatient care use. That is going to be limited to only about half of Medicare beneficiaries who are fee-for-service, which is a limitation, but the data I'll show you today are not limited. They do cover the full population. Then in terms of looking at HbA1c, which is another one of our main health outcomes, We will actually be doing that using electronic medical records, since we can't do that in the claims data. And by necessity, that means we would have to limit the sample to this particular geographically limited sample that's going to be Wisconsin Collaborative for Healthcare Quality. It has health systems from Wisconsin and neighboring states, and does have those measures of HbA1c for an affected population, and a population unaffected by the policy. So happy to chat more about that, time permitting, if folks are interested. Okay, so the main questions and measures for today. First, you may wonder, was the policy implemented as expected? So, first things first, you know, was it implemented in the sense that did anyone, do we see in the data anyone paying more than $35 per 30 days supply of insulin? Maybe it was not fully implemented. You also might be wondering, is this just mostly a PR stunt and no one ever paid $35 or more before the cap? That's going to matter as well. So we'll take a look at that directly to think, who was affected, who actually paid up more than $35 before the cap, and how much did those individuals save. So we'll do that overall and for some of the subgroups of interest. And then third, the data that we have today, we'll be looking at whether insulin use increased after the policy. So different measures here. We will combine both basal and bolus insulin to just look at days supplied. You could do that as total days supplied, number of 30-day supplies, but just adding all that up. You can also look at patterns specifically for basal insulin. So using some of the existing metrics on that, we'll look at proportion of days covered with basal insulin. I don't have in the slides, but we also have a plan to look at medication gap, whether someone appears to have gone 60 or more days in a row without their basal insulin. In future work, we also want to look at initiation of insulin. So what I'll show you today is all about individuals who are already insulin users, potentially looking at whether they're filling more and saving more. But as a separate analysis, we're interested to look at whether more people do initiate as well. So first, was the policy implemented as expected? So we were surprised to find that it was not fully implemented as expected. The proportion of insulin fills that cost the beneficiary over $35 per 30-day supply was similar in 2021 and 2022, the 2 years before the policy, and then fell to about half that in 2023, which is the post-policy year. There was a 3-month grace period of January through March, so we thought maybe that's accounting for it. But even after we dropped that, really over 10% of fills didn't comply with the policy, which was interesting. So taking a look at which fills did not comply with the policy, people were charged more than the cap. We found that these are all actually these non-round number fills. So 30 days, 60-day supply. Maybe the pharmacy might have a flag set up to just, or the health plan would. But when you have these sort of non-round number days supplied, it seems that it sometimes isn't caught and isn't adjusted. All that said, it did for these non-compliant fills, the fills with out-of-pocket cost more than 30-day supply for individuals who ever paid in previous years more than $35. How is this looking? It looks like people were charged on average about $10 more than they should have been for their insulin. So, of course, significant, and that can add up over time, but that just gives you a sense of the scope of the problem. It wasn't necessarily the case that they were charged the full amount pre-policy, but perhaps not as little as they should have been. So looking at who had any non-compliant fills, we have some of these predictors. This is currently for 2022. We'll be revising that for 2023. But overall, among insulin users with Part D insurance, about 21% of them did have one or more non-compliant fills where they were charged more than the cap in 2023 for their insulin. And some of the predictors of having a non-compliant fill were being in fee-for-service, older age, being non-Hispanic, white, and having higher income. That last one might make sense because, again, if you do have sufficiently low income and assets, you do get some protection from cost sharing, which could also prevent you from being overcharged. So, among the insulin users who were affected by the policy in the sense that they, in the past, had paid more than the cap for their insulin, we looked at how much they save on their insulin. So, to answer this, we really need to first define these affected insulin users. And like I hinted before, this is where it helps us to have a group, even within our data set, despite the fact that they all have Part D coverage in name, affected by the cap, that were not practically affected by the cap because they already had that low income subsidy coverage. So we will be using a difference in differences analysis to compare trends for those insulin users that did pay over $35 for insulin in the recent past versus unaffected folks who did not pay that much for insulin the year before the policy because they had this sort of stable protection from cost sharing. It's not just that they had, very few fills or something idiosyncratic about, 2022. It was just that they have, as a, matter of course, cost sharing protection that's kind of long lasting and tied to them. We had a couple other exclusion criteria I'll mention before moving on to show you the additional change experienced by the affected enrollees after the policy. So first, we wanted to make sure that we excluded insulin pump users from the sample because insulin that's filled with an insulin pump is affected by the policy. Medicare does limit, the cost sharing for that to $35 per 30-day supply. It was, it came into effect at a different time of year, but that's not insurmountable. But the issue is that cost sharing for insulin delivered through Part B, which is a different part of the insurance, so which would be the insulin pump insurance, insulin pump method of coverage, that actually can be subject to further reductions in cost sharing that we could not observe in our data. So some Medicare enrollees have a Medigap policy that will reduce their Part B cost sharing in ways we can't observe, but not their Part D cost sharing. So that's why we have that limitation that we can't study the insulin pump users. The other exclusion criteria that we implemented was to not include people who are either in a nursing home or receiving equivalent care at home through home and community-based services. And the reason for that was these folks had very strong protection against cost sharing. They pay nothing for their insulin, no premiums for their health insurance, but they also have potentially really different health trends than other enrollees, and they would have otherwise all ended up in the comparison group. So we just wanted to sort of balance the affected and unaffected treatment and comparison groups on that characteristic by excluding them. Okay, so and please interrupt me with any questions. So who are the affected insulin users if we have these treatment and comparison groups? By design, low-income subsidy enrollment was much higher in the comparison group. But these groups were somewhat similar in whether they used any bolus insulin the year before the policy. And had somewhat similar distribution of number of other anti-diabetic drug classes, use of some drugs indicating comorbid conditions like ACE inhibitors or statins. Comparison group was more likely to be enrolled in Medicare Advantage and possibly a little bit younger as well. Okay, so how did the out-of-pocket cost for insulin look for this group that was affected before and after the policy? So you do see that before the policy, our group of insulin users were paying more than $35. That's how they were selected per 30-day supply. You can see you get a little bit of a discount if you buy in bulk, buy a multi-month supply. And then in 2023, the out-of-pocket cost per 30-day supply really hovers, at or just below that $35 cap. So doesn't seem to be the case that insurance companies went beyond above and beyond the cap. It's pretty much just the cap. That said, that change really added up for them. So the affected enrollees spent more than $200 less on their insulin in 2023 than they did in 2022. So this graph shows the cumulative amount out of pocket that they had spent thus far in the year. And you can see that strong upward trend for the treatment group, less so, of course, by design for the control group. They had less cost sharing to begin with, and see that drop in 2023. Of course, that it matters how much insulin you're buying. The total cost depends on how much you're buying. So if we look at out-of-pocket costs per 30-day supply of insulin, we do see that visible decline in 2023. But we also see for this treatment group, their out-of-pocket cost per 30-day supply was really strongly varying throughout the year prior to the policy. So there was a spike, people paying $70 for a 30-day supply if they filled it in January versus something like between $40 and $50 if they filled it in December, which could be a point of stress for some individuals who may not have the same amount of money at the ready throughout the year. Versus after the policy, you don't see that January spike anymore. And out-of-pocket cost, you still have that downward slope as people start to meet their deductible or hit the more generous coverage phases throughout the calendar year. So in total, if you add up all the days supply that they did receive and all the out-of-pocket costs, by the end of the year, you can kind of see that there is this jump downward in about $20 less per 30-day supply in 2023 compared to 2022. And again, stable trends for the comparison group that were unaffected by the policy. So if we look at this separately by subgroup and formally compare it in a difference in difference analysis, we can track the additional change that was experienced by the affected enrollees in 2023 after the cap compared to the less affected control or comparison group. We see pretty strong decreases in out-of-pocket cost per 30-day supply across the board, and a little bit larger effects for fee-for-service beneficiaries. So the Medicare Advantage plans did tend to have a little bit more flat and stable cost sharing for insulin at around $50 throughout the year, just based on the way they've designed their plans. Okay, so the next question would be, people are paying less per 30-day supply. That's what the policy was intended to achieve, and so we do see that. But in order to move the needle on health, we may want to know whether insulin use increased. Did this reduce this skipping insulin or insulin rationing, using other drugs instead of insulin because of the cost? So here we do see relatively small increases in insulin use overall. Here you can see the graph of cumulative days supplied throughout the year. In the past, there was a little bit of a gap between the treatment and control group that was similar by December in terms of how many days supply they filled. Similar in 2021 and 2022, and then that visibly closes a little bit in 2023 with the treatment group having more days supplied than they did in the past, but not very dramatically so. So in total, that would add up to an additional 8 days supplied with insulin after the policy, for that group of affected enrollees. We do see a larger increase for that group that I mentioned that was not so low income that they had no cost sharing to begin with, but still low income enough that they had a little bit of relief. They were identified as a group that needed a little relief from cost sharing. So as you might expect, this group was more sensitive to and responsive to a decline in price. because of their lower income and assets. So in terms of proportion of days covered, we see relatively um, parallel trends throughout the year. Oh, yes, we have a chat. Okay, great. Um, for both the treatment and control group, and this is proportion of days covered with basal insulin now. So shifting our focus from any insulin, including bolus and basal, to just basal, following the PQA metrics of checking proportion of days covered with basal insulin. And you see a little bit of a increase here as the treatment and control groups do diverge in 2023, but pretty small. Oops. And so that really is only about a 1% increase compared to the baseline in insulin adherence, proportion of days covered. Although, again, you do see a slightly larger increase for that lower income, but still affected population. So turning to our next steps and future analyses, this is just the raw data. These are just the raw data on how many people are starting to use insulin. I would say offhand, there's not a very visible increase in a surge in new insulin usage starting in January of 2023 compared to what you see it just in annual fluctuations in people starting new prescriptions in previous years. Okay, so in summary, what have we found so far? So first and importantly, we found that the policy was not completely implemented. So even this is even after the January through March grace period that plans had an opportunity to transition to the new out-of-pocket cap. Some people were still, about 20% of insulin users still paid over $35 for a 30-day supply of insulin after the cap. And have overcharged. They were typically overcharged by about $10 per 30-day supply, which can make a difference. Um, so despite that, we did find that the policy to some extent did what it was what it intended to do. Out-of-pockets did decline. Out-of-pocket costs did become more predictable and stable throughout the year, which can make life easier for enrollees. And it would add up to over $200 in annual savings. And we found that insulin use and adherence did increase as we'd hypothesized, but only slightly, with perhaps slightly larger impacts for people with lower income and fewer assets. So how does that compare to the literature? I will say for this, we can turn to other similar policies. So there have been evaluations of the pilot program that matches this policy, the senior savings model, where those, like I mentioned before, some plans could opt into having a voluntary out-of-pocket cap on their insulin of the same amount. We can compare it to the literature of the out-of-pocket caps on insulin that states have enacted, which have ranged, from $30 or so to up to $100 cap, and those would be for a separate set of state-regulated plans. And this literature is a little bit mixed. So I would say our estimated savings per person is smaller than what was projected originally, but similar to the savings that were found in the pilot program. The 2% increase in days supply that we found was smaller than our team had found in a previous paper that only looked at the number of insulin fills. And that may make sense because here with days supplied, we can capture the fact that someone may have filled a 3-month supply, for example, and still had that in hand versus just looking at the month that the actual fill occurred. With cost sharing being lower in December, you might expect that more people would fill in December and then just hold on to that day supply and use it those first few months when cost sharing is particularly high. And then compared to the literature, that's smaller than what was found in the senior savings model, but larger than the null findings from the insulin caps, out-of-pocket caps enacted by states. Likewise, the 1% increase in adherence that we found with a 20% decrease in insulin out of pocket is smaller than the implied elasticity in demand for insulin found when people hit the catastrophic coverage phase. I will mention that that is a really just sudden and large change for people, that their insulin costs can just in the middle of the calendar year double with, what may feel to them like very little warning. So that, versus our out-of-pocket cap was well publicized, and everyone knew this was coming into effect in a particular calendar time. So again, the mixed literature, where our findings are smaller than many, but of course larger than the null effects for some of these state level cap studies. Okay, so stay tuned. There's more to come. We wanted to check whether more people got Part D insurance or started using insulin after the policy. So recall that the findings I shared today are all focused on existing insulin users, looking at whether people who we would expect to be affected or unaffected based on their past fills, um, saved money, filled more, et cetera. But there, of course, could be new people trying to use insulin as a result of the policy now that it's known to be cheaper. Um, we can also use matching methods to balance the treatment and comparison groups further on key characteristics. And then, of course, per the grant, we are going to be looking at the health effects and the unintended consequences of the policy. So changes in HbA1c, seeing whether there are increases in premiums in locations that have many insulin users after the policy, seeing whether even standalone Part D plans leave the market as a result or after the policy in locations with many insulin users, these sort of unintended consequences. Oops. So that is all I have, and I'm happy to take questions. Questions from the group?
I have a question. That was a great presentation. This is Ilana.
Hello.
Yes, my
I'm
question is some people on insulin are able to discontinue, particularly now with like these newer class of type
Yeah.
2 medications. And is that something you have thought about looking at?
Yes, I think this is absolutely the next step, and that actually came up last week when chatting with the HSR group. So yes, we do have GLP-1 data, so we're now extracting that. That was actually one of the other diabetic classes, but we have it monthly. So you may have noticed this decline in proportion of days covered with basal insulin, particularly in 2023. GLP-1 drugs were much less available. They became more available to Medicare beneficiaries in 2023 compared to the past. But the use did not take off as much in the Medicare population as it did in the commercially insured population. Um, so I think it could be a confounder for our study, and we want to adjust for it. And it's good that we can observe it. It's going to be more tricky in the HbA1c analysis because for that, we are not looking at a treatment and comparison group that both have Medicare. We're looking at people with, in that age range where there's nearly universal eligibility for Medicare versus a slightly younger age range. And then it's absolutely a confounder that's a big problem for us because the commercial and Medicaid are getting access to GLP-1s and it's affecting their HbA1c. So that's frankly why the HbA1c are not ready for prime time until we get that confounder measured, which we should be able to do. And if, backup plan, we can also find a comparison group of people who are also age eligible for Medicare, but not insulin users. So that is an available comparison group for the HbA1c analysis. But the problem is, through the channel that we're looking at in AIM-3, the non-insulin users could also have been affected because if they live in a region with many insulin users, the premiums might have gone up potentially. So that is shaping our thinking. Yes, good question.
Thanks, that makes sense. And my other question is I've always been curious about looking at adherence to insulin, and I think the issue has always been that you titrate insulin amounts and they
Yes.
can vary from month to month on lots of different factors. And then I guess like how and people can also stockpile insulin,
Hmm.
right? Like once you reach your
Yeah.
out of
Yeah.
pocket maximum or
Yeah.
deductible, like you can just stockpile for next year. So, like, yeah, how reliable is it looking at adherence to insulin versus like, oral medications, which I think are easier to capture?
Yes, definitely more difficult. Can answer that a couple different ways, and I hope, folks with more clinical knowledge, I'll just be quoting my clinical collaborators, but folks with more clinical knowledge, please jump in if I'm not getting anything correct here. So, so the first point my clinical collaborator made on this was that people, their dosage will change a lot the first 3 months that they're using insulin. So she would have her patients, take their measurements and report back to her, and then she would slowly increase the dose based on what they're finding. So that does work in our favor that these are folks in our main analysis here who have been on insulin since 2021. And so at least that part of it has happened for them. If they do change their dosage throughout the year, we do focus on day supply for them, and we're trusting the day supply that they list in the data. So if the number of units that corresponds to a day supply for them changes, that would be baked into this. But as you say, if people do save when, you can see that in our data too. People save when they buy a multi-month supply. And so, not only because, it looks like it costs a little bit less for multi-month supply per day supply, but also because you can stockpile it at the end of the year when your personal cost sharing is lower. That would mean that it that gives us the potential to miss that their dosage has changed in the meantime if they're buying like a 3 month supply or something like that. So we do what we can, which is basically just to take it at face value that this was, and of course to focus only on basal insulin when calculating proportion of days covered, since for bolus insulin people may not, it's keeping it as needed and you may not use it all.
Thanks.
There's a comment in the chat. Would you like me
Oh,
to read it, Dr. Myerson?
um, see it here. I can read. Oh, hi, Rosette. Might want to consider differentiating basal insulin from premeal insulin if thinking about GLP-1s or people on multiple daily doses of insulin, not just basal. Um, that's helpful. I mean, Rosette, did you want to explain anything a little bit more about that? Or
Yep, sorry. Great presentation, Rebecca. Can you hear me okay?
yeah.
This was just really interesting to kind of see what's going on with your work and cool to learn about the research that's happening around this thing that's very much influencing our clinical practice, I would say, or at least the way that we are trying to practice. The GLP-1 question in particular, I think is just something great to kind of like use as a springboard and maybe brainstorm. In our guidelines, I'm trying to remember, like I think the ADA guideline, there's like even like a specific part of the algorithm that basically says if you're getting ready to put people on multiple daily doses of insulin, make sure they're on a GLP-1. So like
Mm.
the new starts, you can think of it that way because the GLP-1s are really they are able to help
Oh.
mealtime coverage really well. And so, um, I think a lot of us like to avoid multiple daily doses of insulin because it's very complex for our patients to have to do that. And so the GLP-1s kind of open that door a little bit better. Like basal insulin is not so hard, especially when you think about it. Like they're giving themselves a shot of a GLP-1. And so doing a shot of basal every day is not too bad if you have like fixed doses of that.
Mhm.
Multiple daily doses gets hard for the patients, and it just gets more complex. So if we can avoid that, that's like a good thing for us. So GLP-1s may help with that. So we kind of want to think about that. But then also, there are some populations of patients, and I would say many of the patients we treat at Grady, for example, have been on very high doses of 4 times a day shots of insulin for a long time. And so it could be interesting to see that if they get more access to GLP-1s, it's almost like you don't expect the basal to come off first, but maybe, do they come down on multiple daily doses? I think there's just a lot of room to think about it. I'm sure you've got great folks kind of informing it, but something to think about.
Yeah, thank you. And I guess I'll show my ignorance here. Do you mean bolus insulin? Because
Yeah.
we have basal and bolus, and then we also have folks on mixed or regular. So that those would be along the lines you'd be thinking to separate this out.
Right. So bolus is like, in my mind, I usually think of bolus as like bolus dosing before each meal. So you're using a very rapid or short acting.
Mm.
But you make a good point, which is like we still have some people on like 70/30, which is like an older form of insulin where it's like a mix of
Mm.
intermediate,
We do have some, yeah,
and
people
regular. Yeah. All of those are just considered much more complex. It's none of those are the same as just having someone on Lantus basal once a day, right?
Mm.
And a lot of those like other combos is really about doing better coverage for how they eat. So like, you know, patients that are working full time and cannot keep insulin at work in a refrigerator, they can't necessarily do 3 times a day while they're at
Mhm.
work. So you may put them on something else. There's also, a cheaper version of insulin that you can get from like Walmart over the counter sometimes. So people do that. But I just think the GLP-1 question with insulin is really a cool space to be thinking about. So excited to hear what you guys will do there too.
I mean, honestly, we were thinking to do something pretty simple, but maybe we should talk offline. I would just to adjust for whether they're on a GLP-1 concurrently, if that's a potential confounder that would reduce, the need to be on basal insulin, and thus affect proportion of days covered. It seemed odd to me that proportion of days covered is just going down throughout the period, and particularly so in 2023 when GLP-1s become more available.
Yeah.
Um,
Do you have, this is just me not knowing what you would have access. I guess you would, since you have EMR. I think this is where it's like, actually, if you can get a data source that tells you not just if they're on basal, but like how much basal, um,
yes, we
or
do
like
have.
if they're on bolus, but not just if they're on it, but like how much. Because
Mhm,
um, I just think there's a lot that we can learn there. I get it that that may not change the cost question because maybe they still need the vial or the pen,
mhm.
but um, we've talked before in things like weight, like that really matters, right? Like how much insulin they're taking. And there's a lot of good things that can happen by reducing insulin doses or rate of hypoglycemia. Like that's an
Mm.
outcome that you might want to think about because if you're making those switches to GLP-1s, you should have lower risk of hypoglycemia.
That definitely. So we are looking for hypoglycemia. Um, we'll be looking at emergency department use. I'm just going back to the Ames. And in the Medicare claims data, since it's such a rare outcome, we wanted to have like the largest data set possible for some of these, and using the prevention quality indicators from HRQ for the preventable diabetes related complications, visits related to preventable diabetes complications. In the electronic health record data, what we have is pretty limited, I would say. So we have the HbA1c, all their HbA1c, values and when it was taken. We have BMI, but my collaborator had mentioned that we should still probably keep it fairly broad in terms of, want to have people reaching an 8% target because we won't have enough information to know who would benefit from a stricter target um, for that. But we were actually excited to, have the HbA1c as part of the analysis because I know there are some groups, including folks at Emory, who can use that to project what the future health effects might be, which is important because this policy was cleanly implemented in 2023, but then there start to be some policy changes in Medicare that could be potential confounders in 2024, and also some insulin manufacturers changed their list price in response to another policy in 2024. So we won't have a very long follow-up data without some contamination. But it sounds like your suggestion is that maybe we should also look at units of insulin filled, not just days supplied. Yeah, that was an interesting suggestion.
I think so. I mean, I think we're totally in like the exploratory zone of this, but like
Mm.
you've got two kind of shocks to the system happening at the same time. One is that there's this um, economic side of like the pricing on insulin. The other is the more widespread availability of GLP-1s. For patients with diabetes, they've actually had access to GLP-1s even before that. It's just that we're seeing more options available. But it may just be something exploratory to be thinking about because I'm thinking of the patients that we treat is that they may not come off of insulin altogether, but we may get
Mm.
them down a lot.
Mhm.
So if they're on basal, maybe it's coming down on the amount of insulin they're taking. If it's basal bolus, maybe they're not taking as many bolus doses as they were before.
And
Um,
their day supply would reflect that then, but only when they fill again, I suppose.
yeah, it would. See, I guess the reason I'm saying think about units is because, like, so what if the change in units changes the number of pens you need? Or, like,
Mhm.
change, you know what I mean? Like,
Yeah.
it depends on where they're falling on the cut point of the amount of units. So if you could use it almost continuously, like,
Yeah,
or,
we
or
can. We can.
describe
We
it
just didn't know what to do with
continuously.
it.
Yeah.
But
And
yeah, that's a good
I think we
suggestion.
could definitely brainstorm it a little more if you're interested. And I feel like we could talk to folks in the endocrine group that, maybe
Mhm.
have more quantification of like how much insulin they're seeing coming off. The reason I
Yeah.
think this is because I've asked folks before, like, so when I started GLP-1, something that I get nervous about if they're on insulin is could they get more hypoglycemic because they don't
Mhm.
need as much insulin. It's not the GLP-1 I'm worried about. It's that they're still on the
Mhm.
same dose of insulin, right? And so we
Mhm.
usually will like reduce a little bit of their insulin
Mhm.
dose because we know that they're getting, these are for people who were probably controlled beforehand, but we're just trying to get them on
Mhm.
a better med, let's say.
Mhm. Mhm.
So we'll reduce their insulin a little bit, but there's not a great map for that I know of yet, like by how much do you reduce
Okay.
insulin. So
Interesting.
I'm just trying to think of like, I think in a good way, the good problem you're going to have is like it's not so clear cut anymore
Mhm.
that the hypoglycemia outcome reflects access to insulin only. Like there could be other things that are kind of happening there.
Yeah.
Even A1C control, like the A1C number can come down a lot, but just trying to think through. I feel like this is like a
Yeah.
whole other part of your stuff that could be really more like the exploratory side. But we could
Yeah.
think,
Yeah, great. Thank you. It's a timely topic.
yeah.
We have this is Young Rock Hong. Wonder about the other subgroup, including dual eligible beneficiaries. Outcomes were similar. Um, it would be great if you were able to talk more about the potential spillover effect with the reduced out-of-pocket spending on insulin. Could it impact other aspects of diabetes care or oh yes, the ability to afford other medications. So yes, that is on our to-do list to look at total drug spending. And that's something you may be wondering, perhaps people are filling the amount of insulin that they want to fill, or that their clinical team recommends they fill, but then now that they have extra $200, what would they spend it? I mean, of course, all we can observe is the drug spend, but do we see them, adding more medications? Just, if a drug spend stays constant, either they're, switching or adding something else. Um, so that's a great suggestion. And we could actually, I guess, do subgroups. Of course, in the claims data, we don't have we have, limited information, but we do have, these sort of proxies. I'll show you that, what other drugs they were on at baseline, whether they do, have multiple forms of insulin and whether they appear to have other comorbid conditions. Um, for dual eligible, basically they are, folding into our comparison group. That was the thought, basically, that there are some folks who are already protected from cost sharing, and if the policy does nothing for them, that you know, uh, would would be expected, but then they also having data from them is helpful to get those overall trends in proportion of days covered, so we can net out the additional changes associated with the policy. I'm happy to chat more if that doesn't cover the question. Any
All
other
right.
questions? Yeah.
I was just gonna say the same thing.
Thank you for the feedback.
Well, it looks like we don't have any more questions, Dr. Myerson.
Sounds good. Well, if anything else comes up, please email me. I'm happy to keep the discussion going. And thanks again.
Thank you so much.